started. We're about 5 minutes delayed, but that's okay. So thank you so much for taking the time to join us this evening. My name is Jillian McConnell. I am a knowledge broker with Brain Exchange. And on behalf of my colleagues from the MS Society of Canada, the Saskatchewan division specifically, we welcome you and are so pleased that you're able to join us. So today's webinar is the 5th of an 8-part learning series brought to you by MS Canada. And I will post a link in the chat pod if you're interested in finding out more about our past and future events. Before we begin, I do want to take a few moments just to review the technology with you. So the audio is provided over the phone, so if you're hearing my voice, then you're in the right spot. And of course, the slides for today's event are provided through the webinar link that maybe a couple people have had problems with, but hopefully there's a majority of you that got on just fine. I do want to point out that on the bottom left of your screen, and that's where some of you have already been chatting with me, and that is your chat pod, and that's where you can connect with me during the actual presentation and communicate with me that way, because of course all of the lines are going to be muted. Excuse me, and this is also where you can send me the questions during the Q&A portion. I do want to let you know that, as I said, the lines are muted, and that just helps us minimize background noise and private conversations that you might be having on the side. If you do need to ask a question, please use the chat pod, as of course we won't be able to hear you. The presentation itself is being recorded, as I mentioned, and so within a week or so it will be available on the MS Canada website as well as the Brain Exchange website. So I invite you to take a look there as well. So for the purpose of today, those are the only features you really need to be familiar with. The webinar is scheduled to be 90 minutes in length. Our presenter will speak for about 60 minutes or so total, and then we'll have the remainder of the time for Q&A and discussion. I do ask that people refrain from asking questions in the chat pod until the end of the discussion, unless, of course, the question is technology related, and then we'll do our best to help you out. Okay, so now that the technical aspects are taken care of, I do want to take the opportunity to review a few bits of information that the MS Society has asked that I share with you. So on behalf of the MS Society of Canada, wishes to gratefully acknowledge the educational grant that it received from Biogen, which makes possible the research, which makes possible the sessions that we'll be having for the past 8 webinars or future webinars as well. So the MS Society does not approve or endorse or recommend any specific product or therapy, but provides information to assist individuals to making their own decisions. And identification of needs, determination of objectives, selection of content and speakers, educational methods and materials are the sole responsibility of MS staff and MS Society staff and the advisors. And just quickly also to review the mission statement of the MS Society of Canada, and that is to be a leader in finding a cure for multiple sclerosis and enabling people affected by MS to enhance their quality of life. So it's now my pleasure to introduce our webinar topic and presenter for this evening's event. This evening we'll be talking about mood, multiple sclerosis, depression, cognition, and fatigue. And we're so pleased to have Anthony Feinstein with us today to present. Anthony Feinstein is a professor of psychiatry at the University of Toronto and a neuropsychiatrist. His research and clinical work focuses on people with multiple sclerosis, traumatic brain injury, and conversion disorder. Over a 3-decade period, Feinstein's work has focused on determining brain image correlations of depression and pseudo-bulbar effect in people with MS. He has also developed computerized methods of detecting cognitive dysfunction with a particular emphasis on the use of distractors. A third strand to his MS work relates to defining the cognitive and functional neuroimaging changes associated with the use of cannabis or marijuana in people with MS. His research has been funded by the Multiple Sclerosis Society of Canada, the Canadian Institute of Health Research, and the Progressive MS Alliance. So, Dr. Feinstein, I'm pleased to hand the baton over to you. The floor is yours.
Good. Thank you, Jillian. Can you hear me?
I can. Thank you.
Good. Well, thank you for that introduction, and good evening, everyone. I'm very pleased you could join me for the talk and the discussion that we'll have after that. So I'm going to run through a lot of information this evening. All of it, I think, is clinically relevant. Many of you will recognize some of these signs and symptoms in yourself, and I'll hopefully be able to speak a little bit about treatment and how this can bring about an improvement in the symptoms.
Well, you listen. That's
I'm going to start off with depression. I should state that at my MS clinic at Sunnybrook, approximately 50 to 60% of all referrals from neurologists mention depression. People with MS refer to my clinic because of concerns on the part of the neurologist or of the family doctor that the individual has become depressed. I've started with a little bit of history. So that distinguished looking man is the great French behavioral neurologist Charcot, and that photograph dates from the 1880s. And Charcot was a very observant neurologist. He was one of the men who first defined the symptoms and clinical features of MS, but he also noticed that people with MS had some difficulties with memory, and they were slow in their responses. They didn't respond as quickly as someone who never had the disorder, and he wondered whether this was perhaps part of the disease itself. A little later in the talk, I'm going to speak about cognition, but I raised this point over here because there's been a recognition going back 140 years or more that MS is not just a disease of neurological dysfunction. It's not just a disease of balance or strength or sensation or vision or bladder or bowel control, but it could also affect what a person feels and how they think. And Charcot back in 1877 saw this in his patients. Now remember, back then there was no MRI, there was no CT scan, there was no neuropsychology. All Charcot had were his eyes and a patella hammer and a pin to examine his patients. So let me start off by defining something for you called major depression. This is a significant clinical problem. It refers to a grouping of signs and symptoms that allows the clinician to make this diagnosis called major depression. And to diagnose this, the person has to have 5 or more of the following difficulties during the same 2-week period. So that's important. This is not how you feel on a particular day, but it's over a 2-week period. And during that time, the person has to be depressed for much of the day, to have a reduced interest or pleasure in activities, to show a change in appetite, with significant weight loss, or in fact a weight gain if the person is eating excessively, to show insomnia, so difficulty with sleep, cannot sleep, or hypersomnia. In fact, the person is sleeping excessively. The individual may be agitated, or in fact slow down, and this needs to be observed by other people. Fatigue or loss of energy is present every day. The person may experience feelings of worthlessness or of excessive, inappropriate guilt. The individual may have a diminished ability to think or concentrate, and there may be recurrent thoughts of death or suicide. So you can see from that list of symptoms, these are very significant behavioral changes, and if 5 or more of these difficulties are present in a 2-week period, then that person is diagnosed with major depression. Now you may ask, well, what happens if only 1 or 2 of these features are present? Does that mean there's no depression? Well, the answer is, well, there's no major depression, but there may be less severe forms of depression, minor depression, what we call subsyndromal depression. These are a collection of symptoms that don't quite meet the diagnostic criteria, but they can still cause significant individual distress.
Dr. Feinstein, I'm just going to ask that you speak up a little bit if you don't mind.
Sure. Maybe if I increase the volume on my phone. Hold on. All right. Is that a bit better?
That's a bit better. Yeah. Thank you.
Okay. So just to repeat, you need to have 5 or more of these difficulties to have the diagnosis of major depression. And if you have fewer than 5, that doesn't mean you don't have a problem. It just means you don't have the full syndrome diagnosis. So there are a number of rating scales that a clinician can give to a person with MS to work out how they're feeling with respect to their mood. So the man that you see there with the bow tie, his name is Aaron Beck. He's a very famous psychiatrist. He is the father of something called cognitive behavior therapy, and I'll speak about that later, also known as CBT. But Aaron Beck has developed various self-report rating scales that might be useful. You can see in the top left-hand there the BDI-2 that refers to the Beck Depression Inventory, a scale for depression. Underneath the Beck Hopelessness Scale. On the right, top right, you see the Beck Suicide Ideation Scale. Bottom right-hand side, you see the Beck Anxiety Inventory. And in the middle, you can see the BDI Fast Screen. I've put an orange frame around it. And this is a scale that we like using because it's quick, it only has 7 questions. People with MS find it easy to fill out. But it records the core depressive symptoms that you might see in someone who has a medical illness. Now, why is that important? So I'm going to go back to the previous slide. This is what I showed you a couple of minutes back. You can see all the signs and symptoms of depression, but you will see that I've highlighted some in yellow. And if you read through those, they refer to appetite, or sleep, or fatigue, or the ability to think or concentrate. Well, these particular difficulties may have nothing to do with depression. They may be directly related to the disease itself, to multiple sclerosis. We know that MS by itself can cause difficulties with sleep, or fatigue, or concentration. You don't have to be depressed to show this. And so as a clinician, I have to be very careful when I make a diagnosis that I don't mistake the symptoms of multiple sclerosis for depression. And this is where the scale that's got the little orange box around it is so helpful, because Beck has teased out 7 symptoms of depression that have nothing to do with sleep or appetite or fatigue. They basically refer to how a person is feeling and whether they're pessimistic or they have a negative view of life. And this can be very effective in helping me decide whether the person has become depressed or not. There's another rating scale which I like using, called the Hospital Anxiety and Depression Scale. Some of you who've attended my clinic or been part of one of my research projects will have been asked to complete this particular scale, and I like it because it gives me a score not just for depression, but also for anxiety. And I'll speak a little later about anxiety, which can also be a problem for people with multiple sclerosis. But just like the Beck Fast Screen that I showed you earlier, the Hospital Anxiety and Depression Scale has factored out or removed symptoms that might be directly attributable to the multiple sclerosis and left behind those core difficulties that might be linked specifically to anxiety and depression. So once again, a very useful rating scale to have as part of the clinic, a useful way to quantify how a person's depression and anxiety is doing. So how common is major depression? And you will see there that over the course of the lifetime of a person with MS, the chances of developing a major depression are as high as 50%. So 1 in 2 people with MS may, over the course of their lifetime, develop the syndrome of major depression that I described to you. Now, these data of 50% come from what we call tertiary referral clinics, clinics like the ones at Sunnybrook or St. Michael's Hospital or other big university teaching hospitals that are devoted specifically to people with MS. And because of that, these clinics may have a biased population. Not everybody's going to go to those clinics. So what about going into the community and having a look at the prevalence of depression in people with MS who don't make it into the clinic, when you collect the data from the community? And in fact, what you see there, and these are data that come from the province of Alberta, 115,000 Canadians were surveyed over the course of a 12-month period, and the rates of depression in people with MS were significantly higher than they were in healthy subjects. So when you see an odds ratio over there, it says 3.4, it tells you that the rates of depression are about 3 to 4 times higher in people with MS than there are in the general population. And in people with MS who are 18 to 45 years of age, the 12-month prevalence, in other words, the chances of developing a clinically significant depression over the course of 12 months was about 25%. So once again, very high. 1 in 4 people over the course of a year may develop depression as I defined it for you. And what's interesting is that these rates in people with MS also appear to be higher than they are in relation to other neurological disorders. So there's something particular about multiple sclerosis that might leave the person vulnerable to the development of depression. So why is this so important? Well, depression by itself can worsen cognitive problems, and I'll speak about cognition later. There's always a concern that if someone becomes severely depressed, they can become suicidal, and one has to be careful about that. Depression is has a very important influence on quality of life. In fact, depression is one of the most powerful determinants of quality of life. It's hard to have a good quality of life if you have a significant depression. And here's the other point, which is very relevant. Depression is treatable in most people. So you don't have to feel this way, and I will describe the treatment later in this presentation. I just want to speak a little bit about suicide because it's such an important aspect of clinical care. You know, one of my jobs as a physician is to keep people safe. You don't want to lose a person from suicide. And data that comes from MS clinics shows that 1 in 3 people over the course of their lifetime with MS will think about suicide. About 6% of people will attempt suicide. And the risk factors for becoming suicidal are if you have a major depression, if the depression is severe, if you are socially isolated or living alone, and if you tend to misuse alcohol. So those are the risk factors that clinicians have to look out for in their patients: depression, severity of depression, social isolation, and alcohol abuse. But this is where we have a challenge. And once again, these data come from neurological clinics. Data show that up to 1/3 of people who become suicidal are not receiving treatment for their depression. That 2/3 of people with a clinically significant depression had not been receiving treatment for their depression. And the study that I completed, I showed that of 9 individuals who had attempted suicide, they hadn't succeeded, but who had attempted suicide, all were depressed. 4 had never been given any kind of medication or treatment for their depression. And these kind of data are not unique to clinics here in Canada. There's a study that I quote there from my colleague who worked at UCLA in California, David Moore, and he showed that over half of depressed people with MS in a neurological clinic were not receiving medication for their depression. And if those individuals were receiving medication, they were not getting the proper dosage. So this is a very important slide that I put up over here, showing you that depression comes with very real consequences and is often undertreated when it's present. I'm going to skip over the next slide and just go on to why are rates of depression so high in people with multiple sclerosis? Now you may say, well, of course they're going to be high because we've got this tough illness to live with. There's no cure for MS. And so you become depressed in response to that. And of course that's a valid argument, and I will discuss it a little later. But first I want to speak to the importance of a brain MRI in someone who's depressed. So the study that I put up in front of you, where you see lesions in the left arcuate fasciculus region and depressive symptoms. Well, this is a very important paper in the MS literature. It comes from a Spanish group. If you look at the date down at the bottom there, it says 1997. And this really was the very first study to show that in some individuals you could link depression to what was going on in their brains. When you did an MRI, you would see lesions in a particular part of the brain that was more frequently involved in depressed people. And once again, I'm going to move my cursor across the screen. And Michelle, tell me whether you can see this. But over here, can you see this?
No, we can't see your cursor.
All right, okay. So what you see in front of you is something called a scatter plot. And at the bottom, you will see Beck scores. And as the numbers go up, 5, 10, 15, 20, 25, that tells you increasing scores on the Beck depression scale. So the higher numbers indicate more depression. When you look on the numbers going up, 0, 50, 100, 150, 200, that refers to the area
of the brain lesions in a particular part of the brain called the arcuate fasciculus. And what the Spanish group showed was that if you had a particularly high lesion load in a part of the brain called the arcuate fasciculus, you were more likely to become depressed. Very important paper because we established a link here between brain changes of MS and depression. So this led my group to go back and do a study in which we looked at the brain in even more careful detail. We didn't just measure lesions. We also measured where were the lesions placed, and we looked at the size of the brain to see whether there'd been any shrinkage, or what we call atrophy. And what we showed was that if there were lesions in frontal parts of the brain, and if indeed there was some atrophy in parts of the brain that we call the temporal lobes, then those individuals, because of these brain changes, were more likely to develop depression. And this is where the story gets even more interesting, because many of you will have seen your brain MRIs, and you will see the characteristic pattern of lesions that you see in someone with MS, the white plaques that you see on your MRI. But we now have an ability to look beyond the plaques, to look at those parts of the brain that look normal to the naked eye, and we can extract information, imaging information from those parts of the brain that give us a clue as to whether this normal appearing brain tissue is in fact normal or not. And one of the imaging techniques that we use is called diffusion tensor imaging. And we apply this to a group of people with multiple sclerosis who had depression. And what you can see over there are some nice colored pictures of the brain, and you will see, if you look at the colored picture, you will see the central part, the big blue area. Those refer to the ventricles, where you have cerebrospinal fluid. If you look on the periphery of the brain, you see another area in blue. That refers to the cortical gray matter. And between the two areas of blue, you see the cerebral white matter, and you will see the lesions very nicely marked out in red. Well, if you look at parts of the brain where there are no lesions, and you extract information using diffusion tensor imaging, what you're able to show is that in people who are depressed, there are going to be more changes. So there is now compelling evidence using very sophisticated brain MRI that individuals with depression, individuals with multiple sclerosis who have depression, may indeed have a higher lesion volume in certain brain areas. Their brain may in fact show a little bit more atrophy or a bit more shrinkage. And in fact, when we look at those parts of the brain that look normal to the naked eye, we can extract information to show that indeed there are pathological changes over there that are also linked to depression. And this is just to show you a very nice picture of a brain. Imagine that you were looking at yourself in profile. This is what your brain looks like in profile. It's something that we call a sagittal section. And you can see that we've marked off the areas very nicely in different colors. Well, if you look towards the front part of the brain, there's a very big area in blue. And just underneath it, there's an area in gray. Well, those are the areas that are often involved in people with depression. And if you look in the central part of the brain, there's a green area with a little line going to it that says PBG/T. That part of the brain may also be associated with depression. So there are going to be discrete brain areas that, when they're involved, leave the individual more vulnerable to the development of depression. And this is just to show you once more some really nice brain pictures. This comes from the diffusion tensor study that I described earlier. If you look at the colored pictures on the right, the colored brain regions, you see them in multiple colors. That's all normal appearing brain tissue in which we've gone down and looked within those various regions to see, is in fact the brain normal? And we find evidence of pathological change if the person is depressed. So why am I going on at length about the brain imaging? Well, I've moved on to a slide over here which shows you the following. If there are brain lesions and atrophy in certain parts of the brain, it can explain about 23 to 24% of what we call the variance as to why that person has become depressed. In other words, the brain pathology can explain about 24% of the reason why this individual has become depressed. if we improve our brain imaging by looking at normal appearing brain tissue, the diffusion tensor data that I showed you earlier, and we bring that into the equation, and we combine that with the lesion volumes, and we combine that with the atrophy or the shrinkage, in fact, that can explain about 35% of the reason why a person becomes depressed. And if we actually go to the brain lesions themselves and using very sophisticated MRI, look inside the lesion to see what degree of brain change is going on inside the lesion, and we incorporate that into our analysis, it can explain about 40 to 45% of the reason why a person has become depressed. So what I'm trying to say over here is this. A brain MRI, a sophisticated brain MRI, can, in certain people, explain up to 40 to 45% of the variance or the reason why this person has become depressed. Clinically, this is extremely important because a person with multiple sclerosis can come and see me with a depression. They walk into my office. They don't have significant physical problems. They're walking well. Their vision is fine. Their balance is good. But they're depressed. I take a history from them, and it turns out that their marriage is fine. Their kids are good. They don't have financial worries. But still, they're profoundly depressed. And they say to me all the time, why am I depressed? You know, I know that I've got MS, but my disease is mild. I'm not troubled physically. My life actually is good. My marriage, my relationships, my children, everything's fine. Why have I become depressed? And the answer is possibly these are the individuals who show the kinds of brain changes that I've described to you. So a brain MRI, in fact, can be quite helpful to a clinician in trying to determine why some people with multiple sclerosis become depressed, because there is now a very clear link between the changes that you see on brain imaging in some patients and the presence of a clinically significant depression. And once again, you know, brain imaging is one of my areas, and I'm not going to belabor the point. But if you have a look at the cartoon over there, and you have a look at the green image of the brain, once again, this is the brain in profile, and you see all those thin lines running at an angle through the brain. What that means is every one of those lines refers to a particular MRI slice. In other words, you can look at the brain with multiple slices, which allows you to define the brain anatomy very carefully. And then if you look at the cartoon where you see regions marked out in green and red and yellow, what that tells me, and should tell you, is that there are very specific parts of the brain that when they're affected, leave the person more vulnerable to the development of depression. And these pictures over here refer to parts of the brain called the temporal lobe, or an aspect within the temporal lobe called the hippocampus. And when the hippocampus is affected in a significant way, when the hippocampus shrinks as a result of multiple sclerosis, the person with MS might be more vulnerable to developing depression. And this is a very busy slide, but it just summarizes many of the brain imaging studies done over the years in which the findings are really fairly consistent that depression in multiple sclerosis is linked to lesions or shrinkage in certain parts of the brain, in particular the frontal lobes and the temporal lobes. All right, so enough about brain imaging. If you want to ask me questions later about it, I'd be happy to answer them. But let's talk about other reasons why people become depressed. So in this picture, you see a young man heading off. He's got some rope over his shoulder. He's obviously in robust health. He's going to do a little bit of mountain climbing. And his name is Barbellion. And he wrote a diary called The Journal of a Disappointed Man. And his history is a really interesting one. He lived around the time of the First World War. And when war was declared, Barbellion, like many young men, went to volunteer for the army. And he went for his physical examination. He thought he was in good health. And the doctors examined him, and they found some signs that were abnormal, and they turned him down for military service. And the signs that they detected was the first onset of his multiple sclerosis. And unfortunately, he had a disease that moved very quickly. He also happened to be a wonderful writer, and you can see this is what he wrote in his journal on June the 15th, 1917. Now remember, the First World War started in 1914, so he's really had his symptoms for about 2 or 3 years. But by this time, he is so disabled, this is what he writes: I sit all day in my chair, moving 8 feet to my bed at night, and 8 feet from it to my chair in the morning, and wait. The assignment is certain. And so in that very short period of time, this young man has gone from a person who could put a bit of rope over his shoulder and go out and climb mountains to really having great difficulty even moving from his bed to a chair. And then if you look at the next entry in his journal, which is now October the 3rd, 1918, so a little more than a year after the first entry, he says, I'm grateful today for some happy hours plucked triumphantly from under the very nose of fate and spent in the warm sun in my garden. A lark sang, I sat by some Michaelmas daisies and watched the bees, flies, and butterflies. He's basically become, bound to his chair. He can't move around. And when you read his diary, you start realizing what are the implications of his disability. And as he becomes more and more disabled and unable to do things, he becomes more despondent as a result. And why do I put up this particular slide? Well, it's to illustrate the fact that for many people, depression may not be related to the brain changes that I've described earlier, but might be a reaction to their increasing physical disability. That as life becomes more difficult and they are less able to do things, they become increasingly despondent as a result. We call this the reactive type of depression, a reactive depression. You're reacting to your increasing physical disability. Now, of course, brain changes may be important as well. There may be an added reason why the depression comes about. But I just want to make the point that MRI, while interesting and very helpful, cannot explain every case of depression. And as a psychiatrist, it's very important that I look to other factors as well, such as increasing physical disability, inability to do things that formerly you took for granted. And the social scientists know this. I mean, MS is a disease of uncertainty. You can see that at the top of this slide. You don't know what's going to come next. Well, for some people, uncertainty is very difficult to cope with, and that can trigger depression. There may be coping strategies that are inadequate, leaving a person vulnerable for depression. One very bad coping strategy is avoidance, that you stay away from doing things, that you don't reach out for help, that you don't speak about how you're feeling. Avoidance is a poor coping strategy. A sense of helplessness is linked to depression. Poor social relationships are also associated with depression. The loss of recreational activities, likewise. High levels of stress and fatigue. Excuse me 1 second while I just have a drink. So all these factors over here, we know now, are associated with depression. So on the one hand, you've got the brain changes, which are important. On the other hand, you've got all these psychosocial variables, which are just as important. And what's essential for a psychiatrist like me, who deals with people with multiple sclerosis, who treats people, is that I'm aware not only of the brain changes that are important, but also of the psychosocial variables that are put up in front of you here. All right, so I've spoken a bit about depression. I've defined what the clinical features are for you. I've told you about the brain imaging findings, the psychosocial variables linked to it. So let me get on to the good news. Well, depression can be treated. There are 2 randomized controlled trials, RCTs, randomized controlled trials, showing that the old tricyclic drug dizipramine and the newer drug called paroxetine or Paxil might help people with depression. Now, there might be some troubling side effects like dry mouth, constipation, sedation, blurred vision, and some sexual problems, and you need to be aware of those. But medication can, in many people, help with depression. There are 2 drugs that I put up over here that I think might be particularly helpful for people with MS. One is called mirtazapine or Remeron, and I like it because you do not get sexual side effects, you don't get nausea, and so for the most part, that it helps individuals tolerate the drug. Now, one side effect is fatigue, but I've found if the medication is taken at night, it can help a person with their insomnia. And the other one is you just have to watch weight gain with Remeron or mirtazapine because it can increase appetite. The other useful antidepressant drug is a medication called Wellbutrin or bupropion. And once again, that spares sexual function. You don't get weight gain with it. The only real contraindication to taking Wellbutrin is the person has seizures. You can't give the medication to someone who's had a seizure. So here there are two antidepressants that I use in my clinical practice to reasonable to good effect if I come across depression. This is an interesting drug which has just arrived on the market in Canada called vortioxetine. Its other name is Trintellix. And Trintellix, I think, is really interesting because it's known to be a good antidepressant. But in fact, it might also improve a person's cognition. So there's no data yet from people with multiple sclerosis, but there's certainly some data from the general population when individuals become depressed showing that if you take this drug, it might have some cognitive benefits. But we don't have any MS data on it yet. The other thing about vortioxetine is that there are no sexual side effects with the drug and no weight gain. So potentially quite useful. However, the data show that probably the most effective treatment for depression in someone with multiple sclerosis is something called cognitive behavior therapy, which is a form of psychotherapy. And evidence shows that this medication is just as good, that this treatment, cognitive behavior therapy or CBT, remember I showed you the picture of Aaron Beck earlier in my talk, Beck with all his rating scales for anxiety and depression. Well, Aaron Beck is the father of cognitive behavior therapy. And data show that this particular therapy is just as good as the medications when it comes to treating depression. What's of interest is that cognitive behavior therapy can also be given over the telephone. So if you have difficulty getting into an appointment, if you live in a rural area, you don't have transport, you can't get wheel-trans, etc., the data show that therapy given over the telephone to you can be just as effective. And if you look at the bottom over there, there's something called mindfulness-based therapy, which has some similarities to cognitive behavior therapy, but it essentially works on the principle of trying to control your thoughts and managing your thoughts to calm you down and to help you with your mood. There's some data to show that mindfulness-based therapy can also help people with multiple sclerosis who become depressed. So there's another option for you. If you don't want the medication, there's cognitive behavior therapy and mindfulness-based therapy. And this is just to show you that the American Academy of Neurology, which puts out consensus statements from time to time, they looked at evidence-based guidelines for assessing and treating psychiatric problems in people with MS. And in fact, the American Academy of Neurology endorsed cognitive behavior therapy as the most effective treatment for depression in someone with MS. There's now a little bit of data to show that exercise can be helpful as well. Now this is early days in terms of exercise. Studies are few. Once again, you can see at N of 7 over there, I reviewed 7 studies. But there's a little bit of data to suggest that exercise will help a person with depression. I don't think exercise alone is going to be effective, but certainly if you add exercise to medication or to cognitive behavior therapy, it can help. All right. So I've spoken now about depression, and before we leave the whole question of mood and depression, I wanted to tell you about a really interesting syndrome called pathological laughing and crying that can occur in people with MS, because sometimes it's mistaken for depression, and it's not. It's something that's different. So the man that you see over there, his name was Kinnear Wilson, very famous neurologist, and you can see he wrote an article back in 1924. So this is nearly 100 years ago, in which he wrote about a particular problem in neurology that you could sometimes see in people with multiple sclerosis, and he called it pathological laughing and crying. And these are individuals who cry when they don't feel sad, or they laugh when they don't feel happy. So it's really an individual who has lost control over the outward manifestation of how they feel. And this, of course, can be socially very disabling. You can imagine a person can't stop crying in a meeting, even though they don't feel sad. Or a person may be attending a sad event like a funeral and they can't control their laughing, which can be obviously very embarrassing and disabling. And I put this up here to show you, just to remind you, that when we do brain MRI, the findings can account for about 40% of the variance as to why depression comes about, or pathological laughing and crying, the variance is much higher, about 75%, meaning that this is a hardwired neurological problem, that the individuals who show this inappropriate laughter or crying generally have some very significant difficulties going on that you can see on a brain MRI. It can be well treated, very well treated. In fact, low-dose amitriptyline, a drug called Elavil, an old antidepressant drug, can basically turn off this laughing and crying in about 48 or 72 hours in the majority of people. When you see the SSRI, this refers to drugs like Prozac or Paxil. That can also be an effective treatment for this condition. Other treatments are drugs like levodopa, which is in fact a Parkinson drug, and amantadine. And then there's a new drug out in the United States called Nudexta, which is also very effective in treating pathological laughing and crying or pseudobulbar affect. Nudexta is not yet available in Canada. And what's interesting, if you look at the bottom, any of these medications generally turn off the laughter and crying in about 48 to 72 hours. However, when it comes to treating depression, if you look on the right-hand side there, the lighter blue box, medications such as Prozac or Paxil take about 14 days to help a person with depression. So you see a much quicker response in someone who's got the pathological laughing and crying, also called pseudobulbar affect. All right, so for the remainder of my talk, I now want to switch to cognition. So when I said that about 50 to 60% of the referrals that come to me refer to depression in people with MS, the other 40% relates to cognition. We know now that in someone with relapsing remitting MS, about 40% of individuals will have cognitive impairment. In people with secondary progressive MS, the rates of cognitive difficulties go up to 60 to 70%. Very important observation, because if there are cognitive difficulties, you may have more difficulty with your work, with your relationships, with your vocational functions, may even interfere with sexual functioning and activities of daily living. So it's important that you understand what your cognitive abilities are. And these are the cognitive problems that you come across. That there can be a slowness in thinking. Cognition slows down. You do not process information so quickly. There may be difficulty with certain aspects of memory, what we call working memory. The ability to think in the abstract might be affected. Attention can become impaired. You find that you lose your focus. But language is generally unaffected. Language is often spared. And when I put that little agnosia or little apraxia, that means you're able to recognize objects and carry out complex motor movements. So really the main cognitive problems that you see are those of processing speed, which gets slower, and memory is less efficient, and you have difficulty with problem solving. How might this be detected? Well, there are self-report questionnaires. There's one self-report questionnaire, which I will show you. There are brief screening batteries where you see a neuropsychologist and they give you a few tests. There are more detailed screening batteries. Some of you will have had them. There's one they call the MACFIMS, the Minimal Assessment of Cognitive Functioning in Multiple Sclerosis. This refers to a whole battery of neuropsychological tests that are administered. And underneath there you see something called the Mini Mental State Examination, the Montreal Cognitive Assessment. These are very quick and generally not effective screens for cognitive problems. So this is the only self-report measure for cognition in people with multiple sclerosis. It's called the Multiple Sclerosis Neuropsychological Questionnaire. The individual with MS is given 15 questions to answer. An informant, someone who knows the person well, is given 15 questions. This is a very sensitive way of looking at problems. It's not really as good as neuropsychological testing, but if you don't have access to a neuropsychologist, this is the next best thing to do. And this just shows you what it looks like. You see here the 15 questions which you have to fill out. Are you easily distracted? You can just read through them. Do you lose your thoughts while listening to someone speak? Are you slow in trying to solve a problem? Do you forget appointments, etc., etc.? And you rate your cognition on this. And there's a separate set of questions given to an informant, your partner, or a friend, someone who knows you well. Once again, does he or she get easily distracted? You can read through the questions. Why give out two sets of questions? Why one for the person with MS and why one for an informant? Because the data show that informants are often more accurate in their assessment of a person's cognition. What that means is someone with multiple sclerosis may not be the best judge of their own cognitive abilities, but someone who lives with them or who knows them well might be a better judge, and that's why there are two separate questionnaires. All right, so I've moved on to a slide over here that says barriers to an assessment. So we know that cognitive testing requires time and expertise. Not every hospital or center has a neuropsychologist. And so what you find is that there are many people with multiple sclerosis who may never get a cognitive assessment. There's a shortage of neuropsychologists devoted to multiple sclerosis work. If you want to pay for the assessment yourself, this kind of test is very expensive, often costing many thousands of dollars. And so my lab at Sunnybrook, along with other labs, is now working towards developing computerized ways of testing someone's cognition because computers might make cognitive testing more widely available. And I just want to share some of these data with you. So this is a paper that we published showing assessing the validity of a computer-generated cognitive screening instrument for people with MS. Now, once again, you see lots of numbers and percentages in front of you. I just want you to focus on something at the top of the screen where you see C-SDMT. And the SDMT refers to something called the symbol digit modality test. It's a very quick, easy test to do, but it's a very difficult test to do well because it measures speed of processing. And if you remember what I said to you a few minutes back, processing speed is often affected in people with multiple sclerosis. So we developed a computerized version of this test, and you can see over there, it detected cognitive impairment in about 35 to 36% of people with multiple sclerosis. And the test takes about 2 minutes to administer on a computer. So here's the next question. We come back to brain MRI. How might an MRI help someone or help a clinician like myself when it comes to assessing cognitive impairment? Well, we know now that if you add up the lesions in the brain, lesion volume, this correlates quite strongly with cognitive difficulties. So the more lesions, the bigger the lesion volume, the more at risk the person is for cognitive impairment. Atrophy or brain shrinkage is another risk factor for cognitive impairment. And indeed, atrophy or brain shrinkage is even more of a risk factor than lesions. So every time I look at an MRI and I'm looking for lesions, I'm also looking for signs of atrophy to see whether the brain has decreased in size, because if it has, it leaves the person more vulnerable to the development of depression, for cognitive difficulty, sorry. And if you have a look at this scan over here, this is a brain scan, and you'll see in the middle of it two areas marked out in white. That refers to a part of the brain called the thalamus. And the thalamus is a very important structure in the brain because there are numerous neural circuits that leave the thalamus and go into the thalamus. It's like an important relay station for neural networks. And when the thalamus is affected in people with MS, if the thalamus starts shrinking, develops atrophy, then it's a significant risk factor for cognitive difficulties. Now, these nice colored pictures over here refer to a different kind of MRI called a functional MRI. And a functional MRI is as follows. You lie in a scan, and you're given a cognitive problem to solve. And while you're solving that problem, the scan is measuring your brain activity. And so the scans that you see in front of you come from healthy individuals who are asked to do a particular cognitive task. And you can see the areas that light up in yellow and red refer to those parts of the brain that become active when the person is doing this cognitive task. Now have a look at the same series of scans in someone with multiple sclerosis doing the same task. You can see that there's a lot more activation, a lot more areas of red and yellow. Let's go back to the healthy individuals. And now we go into the group with MS, and you can see other parts of the brain are activating. In other words, the brain is having to work a lot harder to solve this problem. This is something called compensation, cerebral compensation. It shows us that the brains are plastic. There's an elasticity to the brain. In other words, although these individuals have multiple sclerosis, when it comes to trying to solve a particular cognitive problem, there's enough plasticity within the brain that other areas start activating to try and help the individual overcome their difficulties. So we see evidence of plasticity over here, but this is not the most efficient way for the brain to work. The brain is having to work harder to do the same kinds of work that a healthy brain would do. And sometimes this starts breaking down, and that's when the individual starts showing evidence of cognitive impairment. What might help a person when it comes to cognition? Well, there's good evidence now to show that intellectual enrichment might help. What do we mean by that? So people who lead a more active life, a life with more intellectual activities, a life that might have some more exercise, for example, or more socializing, or more interesting tasks at work, or someone who does brain puzzles or brain teasers, someone who basically is leading a life that nourishes the brain in multiple ways. This might be protective with respect to cognitive difficulties, even in the context of multiple sclerosis. Very, very important observation this. I hear this all the time when people come and see me. They've seen a neuropsychologist. They've got cognitive problems. They say, what should I do? One of the messages is, try and lead an enriched life. If you're working, try and keep working. If you're not working, use your brain in terms of getting on the computer. Get yourself an iPad. Learn how to use the iPad. Listen to podcasts. Read books. If your vision is not good, listen to audiobooks. Socialize. See people. Do a bit of exercise. If you struggle to walk, do an upper limb exercise. Get some weights. Things like that. All these factors are known to enrich the brain and do offer some protection with respect to cognitive difficulties. And this is just a very nice study showing that premorbid cognitive leisure, in other words, individuals who had a good social life before the onset of their illness, people who were active socially, that in itself can be protective with respect to some of the cognitive problems that I've defined. What about drug treatment for cognitive difficulties? Well, some of you will be on the disease-modifying drugs. There's a little bit of evidence, not strong, that this might help your cognition. I'm talking about things like Rebif, Betaseron, Avonex, Tysabri, Tecfidera. Certainly these drugs are helpful with respect to managing your multiple sclerosis, and there's a little bit of evidence to suggest they may have some cognitive benefits as well. Donepezil, well, that's the drug that was given to individuals with Alzheimer's to boost their memory. It doesn't help in multiple sclerosis. Memantine, another drug that doesn't help. Foraminopyridine doesn't help. Psychostimulants don't help. Cyclophosphamide doesn't help. You can see, basically, medication is not helpful for cognitive difficulties in people with MS. Cognitive reserve, I've spoken about that already. You want to remain active, you want to keep your recreational activities going if you can, enrich your brain. And then at the bottom of this cartoon, you see two things, compensatory methods and cognitive retraining. So compensatory refers to the following. If you've got memory difficulties, what might you do to compensate for them? Well, you make lists, you write things out. In the age of technology, you start using devices to help you. Your cell phone can be invaluable here. You learn to program it every night before you go to bed. You program it in terms of what must I do the next day. You get your partner or your spouse to help you because they may be better at this. And you say, okay, tomorrow I've got to go to the supermarket, I have to pick something up, I've got to do this, I've got to do that. You program it in your cell phone. You put a little alarm in your cell phone. So your alarm rings half an hour before you need to do the task. It may be a second alarm to remind you once the task is done, did I do it? And wherever you go, your cell phone goes with you, acting as an aide-memoire. It reminds you to do things. If you know you've got to go to the supermarket, well, you program your cell phone to remind you to do it. Your phone rings, you go up to the supermarket, and when there, it might ring again, and you look, and you open it up, and you see, well, this is a list of all the things that I need to purchase. And as you walk down the aisles of a supermarket, you have your phone open in front of you, and you just tick off the items one by one. Using technology like this can be a very effective way of minimizing or offsetting difficulties that you might have with your memory. This kind of intervention by itself won't lead to memory improvement, but it can limit some of the problems that you have with memory impairment. At the bottom of the screen, you'll see that cognitive retraining, and that refers to efforts to try and, in fact, improve a person's cognition, to try and improve their memory or their processing speed. And this is quite an exciting area of MS research now because data are starting to emerge showing that there is enough plasticity in the brain of someone with MS that indeed there can still be cognitive improvement with treatment. And this, you see the slide here, an RCT, a randomized controlled study to treat learning impairment in people with MS. And you can see there are two lines. And the blue line refers to people with MS who got treatment for their memory problems. And the red line refers to people who didn't get treatment. And basically, the blue line, a higher line on that graph, shows that the people who got treatment, their memory improved significantly more than the group in red who never got treatment. And when you look at this picture of a brain over here, a functional MRI, what it shows is that the changes in memory that come with treatment are linked to changes on the MRI as well. Neural networks start activating. You see more activation, a healthier pattern of activation in people who got the cognitive rehabilitation. And what's intriguing about these results is that the researchers went back 6 months after they'd completed the cognitive rehabilitation, and they found that the benefits were still there, that the improvement with respect to memory had been maintained for 6 months after the treatment at least. Once more, we come back to exercise. I mentioned earlier that there's a little bit of exercise suggesting it might help depression. Well, there's more evidence now to show that exercise can help cognition with respect to memory in particular and processing speed as well. So aerobic exercise done a certain way is good for the brain and helps cognition. And finally, in conclusion, a few thoughts about fatigue. I hear this all the time in my clinic. People with MS complain of fatigue. It's a big problem. 80% of people with MS will tell me fatigue is a problem. I have to distinguish fatigue from the MS from fatigue secondary to depression. You can do that. People might think that if they fatigue, their cognition gets worse. Well, in some people, yes. In other people, no. The relationship between fatigue and cognitive difficulty still needs to be teased out more clearly. But there are some treatments, and I put it up here for you to see, that individuals with fatigue might benefit from modafinil, methylphenidate, also called Ritalin. Concerta is long-acting Ritalin. Amantadine, perhaps aminopyridine, and natalizumab. Exercise might help fatigue as well, and then there are some behavioral therapies that can help with fatigue. So I can't say you can cure fatigue, but there are some strategies that might help lessen the fatigue that you experience. Okay, so I've spoken now for well over an hour. I hope I haven't put you to sleep, but I think now is an opportunity for some questions.
Wonderful, and I'm going to interject here. Thank you so very much, Dr. Feinstein. This has been such a great wealth of information that you've provided this evening. Before we jump into questions, I do want to mention that there are a couple of options in which you may ask your questions. The first being that you can type your questions into the chat pod, and we already have some people that are doing just that. Just as a quick note, only myself and our presenter can see the actual questions that are coming through, so there is some anonymity there if that's a concern, so not to worry about that. Additionally, if you would like to ask the question over the phone instead, we certainly welcome that option as well. If you want to unmute your line, you can press *7. I would ask only those that do intend on asking a question over the phone to unmute their lines, because it does get quite noisy with some background noise if everyone were to do that. I do also want to note that we will be posting some poll questions during the Q&A. So I encourage you and invite you to answer those before you leave. I think that there's about 5 of them or so. Your answers are anonymous, but they do certainly help us tailor future webinars to meet your needs. Okay, so I'm going to jump right into some questions here as they're coming through. Okay, so this individual says that you just briefly passed over the slide about the MMSE and the MoCA testing. So can you please speak to their accuracy in testing MS patients, please?
Yes, well, thank you for that. Very good question. I put them up because they are widely used. The mini-mental state, MMSE, refers to mini-mental state, and the MoCA refers to the Montreal Cognitive Assessment. They're widely used, but they are not sensitive for people with multiple sclerosis. So, if you've got nothing better, then yes, they can be used. But generally, we don't use them simply because they lack sensitivity. So in other words, someone with multiple sclerosis can perform quite well on the mini-mental state, but still have cognitive problems. And so, you have to be careful with instruments like this.
Thank you very much. Okay, so we're just going to keep plugging along here. Is it true that compensatory items apply with or without MS?
Yes, I mean, you will see them in many other diseases, of course. This is not something that's unique to multiple sclerosis. In the healthy brain, there's no need for compensation. The brain just solves the problem, and the neural networks that should activate. But when you get an acquired brain problem like multiple sclerosis, for example, or say a traumatic brain injury or Parkinson's disease, etc., well then the neural networks might be damaged. And in response to that, you see the brain trying to work around the damage by coming up with different ways of solving that particular problem. And that's where you see the neural plasticity. So you might see the networks that should activate, but you start seeing other networks activate as well, what we call ancillary activation. Other parts of the brain start lighting up, which you would not see light up in the healthy brain. And that's the compensatory mechanisms at work. If those mechanisms are effective, then that person may indeed solve the problem correctly and do well. But it's not an efficient way for the brain to function. That's the first observation. And the second one is that you often find that even in the presence of this compensatory network, even in the presence of brain plasticity, the individual still doesn't do that well on the cognitive task. So yes, plasticity is important. We try and develop it through cognitive rehabilitation, but it doesn't necessarily mean that the person is going to be able to overcome their cognitive deficits as a result.
Thank you. So this individual asks, could depression be an initial sign of MS? i.e. prior to the physical issues or being one of the first signs? So in other words, could depression predict MS rather than MS predicting depression?
Yes, very good question again. There's a small literature that states that depression might be the presenting feature of multiple sclerosis, but it's really not that common. You may certainly get depression early on after the onset of multiple sclerosis, but every now and then I certainly see a person who became depressed and, within, say, 6 months or so had ended up with a diagnosis of MS. So yes, you do see it from time to time. It's really not that common. And then you're always left with, an unanswered question, which is this. Was the depression linked to the multiple sclerosis, or were they just two separate problems arriving by chance at the same time? And, sometimes it's very hard to tease that out. So, if you go and read the literature, the MS literature, you will see the occasional case report of depression as a presenting feature of MS, but once again, not that common.
Okay, thank you. What supplements, or are there any supplements that do you recommend for MS, and perhaps any lifestyle tips that you may offer as well? Do you have anything like those to offer our participants tonight?
Well, I think, the data in terms of supplements is pretty strong for vitamin D. I hope everybody's taking vitamin D. In terms of other potential supplements, not a whole lot of data that things like ginkgo is going to help your cognition. One or two studies, but once again, not a very compelling literature. Lifestyle, I think, is a very, very important question for multiple reasons. Number one, it's a very big mistake to be passive if you've got a disease like MS. You don't want to sit on a couch with a remote control watching television all day long. Even if you have physical disability, you need to try and nourish your brain, as I spoke about earlier. So how do you do that? Well, if you're able to work, then try and work for as long as possible. Keep your leisure pursuits. See your friends. Socialize. See family. Exercise if you can. I mentioned this earlier. If you have difficulty walking, exercise using your upper body strength. Get yourself some dumbbells. Work out a little bit that way. You may want to get a recumbent bicycle so you can lie down and use a bicycle that way. Challenge your brain intellectually. Be on a computer. Get an iPad if you can afford one. Work out how to use it. Listen to podcasts. If your vision is good, read. If it's not, get audiobooks. Do Lumosity. Do brain teasers. Do Sudoku. Really, these things are all part of day-to-day activities that will help you with your illness. Being passive is the worst possible thing that you can do. Being passive is avoidant. You're really not tackling a problem. You're just stepping back from everything, and that's not going to help you cope. And we know that individuals who avoid things are more vulnerable with respect to depression as well. So I think, lifestyle becomes a very important thing to discuss with your doctor, even if you've got significant physical disability. Even if you're struggling, you do need to try and structure your day in such a way that you're keeping your brain active. And I think if you take away one message from today's webinar, it's that one, that notwithstanding your level of disability, try and nourish your brain. Try and keep it active in ways that I've described to you. And that's where lifestyle becomes so important.
I'm going to jump in here, Dr. Feinstein, just as a follow-up. So a couple of individuals have mentioned that often doing the activities that you've just described often will make them tired and sometimes even worsen their cognitive system as a result of that exhaustion. So is it better to continue to work?
No, once again, I think,
even if it does make them tired?
No, once again, you want to bring in some common sense over here. You know what your limit is. There is no one model that fits every person. When I say, keep your brain active or be active, that's going to vary from person to person according to your stamina, according to what you're able to do. I have people with multiple sclerosis who go out and run, 5 kilometers a day. I have other people with multiple sclerosis who, individuals with MS who cannot do that, who might be wheelchair bound. So what are they going to do? Well, they can get themselves maybe some very light weights and do a little bit of upper arm exercise for a minute or two. The point is you want to tailor your activities according to what you can and cannot do. So when I prescribe something like this, it's not because there's going to be one model that fits every person. Definitely not. There are going to be hundreds of variations out there according to your condition. And, this becomes an individualized therapy. What works for me? What doesn't work for me? You will know through trial and error how much can I do before I get tired. There's absolutely no point in pushing yourself to exhaustion. That's not what I'm advocating over here. All I'm trying to say is you need to try and nourish your brain in multiple ways that match your abilities. You don't want to overdo things. You don't want my recommendations to make you worse. But you don't want to be passive with this disease.
Okay, so I'm going to switch gears a little bit here. We have a couple of questions with respect to the use of marijuana.
Right.
And so a number of individuals have requested to hear a little bit more about marijuana use and the use of cannabis and how it may affect cognition instead of other pharmacological options. Would you be comfortable speaking to that, Dr. Feinstein?
Yes. Well, are there specific questions or?
More, yeah. So one is just, and one specifically just says you'd like to hear a little bit more about it. Another person mentions about how it affects or impacts cognition, specifically instead of Elavil, is that, or Elaval?
Okay. So, we've got some data to show that about 18 to 20% of people with multiple sclerosis use cannabis on a regular basis. So about 1 in 5. So, use of cannabis is common. What's interesting is that if you go back in the literature and look at studies done about 15, 20 years back, the prevalence was about the same. So it really hasn't changed a whole lot. About 1 in 5 people use MS. And they use it for multiple reasons. I would say the commonest, here, the cannabis I'm talking about here is the kind that you smoke or you vape or you ingest. I'm not talking about the pharmaceutically manufactured cannabis like Sativex or Nabilone or those drugs. We're talking about the garden variety that's grown. And the reason that people use it varies, but from a medical point of view, pain is often a frequent reason, maybe followed by spasticity or some spasms with respect to urination. So, bladder spasticity, muscle spasticity, and pain are neurological reasons why people use cannabis. Some people use it because they find it relaxes them and helps them with their anxiety. Other people report using it because it helps them with their sleep or insomnia. And then there's going to be a percentage of people who, like anybody else in the general population, use cannabis because this is a lifestyle choice. When you look at the data, once again put out by the American Academy of Neurology, there is a little bit of data to suggest that cannabis might help with pain, neuropathic pain. The data are a little weaker when it comes to spasticity. There's no hard data to show that cannabis is going to help with things like insomnia, etc. I've got a very open mind with respect to cannabis. I learn from my patients who come and tell me, doc, I've tried everything with respect to pain management, and I find that cannabis works best for me. And when I hear that, I of course accept that. Many people will say that cannabis is preferable to using narcotic drugs like morphine or opiates or Percocet or Oxycodone. Many people will say, well, cannabis is preferable to those kinds of medications. The one concern that I do have about cannabis is that we've got a little bit of data to show that it might worsen cognitive dysfunction. So people with MS who smoke cannabis are more likely to have more extensive cognitive problems than people who don't use cannabis. And, we've done 3 studies now funded by the MS Society of Canada in which we've basically shown the same thing on 3 different groups of individuals. So I think like any other drug, the person who takes it needs to be aware of what are the benefits, and I think there are some benefits, and what are the side effects. And one potential side effect, and I want to say it's potential because this might not affect everyone, is that cannabis might worsen your cognitive difficulties. So it's going to be an interesting journey now because, as you know, it's just a matter of time before the drug is legal. Right now, the majority of people who use cannabis either get medical marijuana. I would say about 50% have prescriptions for their cannabis. The other 50% don't have prescriptions. They're just getting it from someone whom they know. I suspect that's going to start changing when the drug becomes legal next year. There's a lot that we don't know. There's a lot that the medical profession has to learn. And I think it's going to be a very interesting journey. So my personal view is that I'm pleased that cannabis is going to be legalized. But I think one has to take the drug knowing that potentially there's the risk of cognitive impairment.
Do you have much information about when cannabis is ingested, in other words, eating it versus smoked or anything like that?
So when you ingest it, it's a slower onset of action. The quickest onset of action is when you smoke it, in which the effects are very quick within minutes and in fact peak very quickly within about 15-20 minutes. When you ingest it, it's a slower absorption, half an hour, etc. So you don't get the rapid onset of, say, euphoria, for example, or relaxation that you get when you smoke it. Many people who use it for medicinal reasons prefer eating it. One of the risks of smoking is that, like any risk of smoking, you have to worry about lung problems, lung disease. Another, preferred method of using it is vaping. So people prefer vaping now to smoking. But I would say that in terms of frequency, I would say ingestion is far less frequent than vaping or smoking.
Excellent, thank you. So there's lots of questions here coming in about cannabis, and I'm trying to balance it out here. I will touch on just sort of as a segue of substance use of some sort. Another person is asking about the use of alcohol, of course with moderation, or are they saying is it better just not simply to use it at all? Can you comment on that?
No. I think, moderate drinking is fine. The Canadian Medical Association says that a man shouldn't drink more than 14 drinks a week and a woman more than 9 drinks a week. So that's considered like the upper limit of, acceptable drinking. But yes, absolutely, enjoy a drink.
Perfect. Okay, so I'm going to change gears a little bit again. As I said, we have lots of different questions, so I'm doing my best to get to all of them, but they're just pouring in, which is great, so don't get me wrong. What I'd like to touch on right now is more about that cognitive rehabilitation piece that you spoke of.
Yeah.
If you can elaborate a little bit more about that, and what steps does that involve to start that process of cognitive rehabilitation?
Right. So you've got to get to particular centers that offer it. This is not widely available. Generally, that's going to be available through, university teaching hospitals and places like that. You will then enter a program that will target your specific cognitive problems. So let's assume that it's memory. The program that you will be exposed to will be one that's devoted to memory. There are a number of ways to do this now. There are some computerized programs that are becoming widely available, in which you can select from a drop-down menu, basically, of what cognitive ability do you want to target: memory, processing speed, executive function, etc. And then you work through a process in which, through building up in terms of your level of intensity, you learn techniques, or the brain learns, to start functioning better, as it were, with respect to memory or whatever. So you will start off with fairly easy tasks, and they will increase in order of difficulty. And as it increases, in a sense, the brain starts improving its ability to remember things. And the data on this is small, but it's exciting because some positive studies are coming through now suggesting that cognitive rehab might help people actually improve their cognition rather than just compensate for it.
Leading to that, so how can you, so for someone who's looking into this cognitive rehabilitation and they're thinking about sort of their cognitive loss in general, and they may be having trouble differentiating between what is normal aging versus like cognitive loss due to normal aging or cognitive loss due to MS.
Yeah, good question.
And
so
how
the bottom
can
line
one
is
differentiate between the two?
you do need to have a neuropsychological assessment. So you see the neuropsychologist, and all the tests that you do are corrected for your age, for your level of education, sometimes for your gender. So we call these, corrected scores, and basically that will tell you whether your impairment is from your multiple sclerosis or not. So yes, those things are factored in when you come to score the tests.
Okay. And in the absence of a neuropsychiatrist or a neuropsychologist, would a geriatrician or a geriatric psychiatrist be sufficient?
Yes, I think, hopefully the person will have some experience of multiple sclerosis, but I mean, if you don't have access to, a specialized MS clinic with the kinds of tests that I've mentioned, but geriatricians aren't going to see people who are under 65 years of age, and we know that MS is the commonest cause of neurological disability in young and middle-aged people, so you're not going to see a geriatrician if you're 30 or 35.
Okay, so these are great questions that are coming in, so I hope I'm doing them justice and I'm trying to get them all in here. To switch gears a little bit again, we have first of all, some questions about whether you need more patients or subjects for research, or if you know of other research going on that people may be interested in getting involved in. Are you privy to that, or would you care to share any information?
That's very kind. Thank you for asking. If I can put in a plug, I mean, we're doing a study now, again, funded by the MS Society, or two studies, in fact. One looking at, what happens to someone with multiple sclerosis, what happens to their cognition when they stop taking cannabis. And so we're withdrawing people from cannabis for 4 weeks, and following them very intensely during that period with brain MRI and neuropsychological testing to see if cognition improves. So if anybody wants to donate their time for that study, that would be wonderful. Another study that we're doing in my lab is to look at using computers to develop ways of testing for cognition, and people who volunteer for that will get a very detailed cognitive assessment as part of the study. And hopefully we use your data to help us perfect these computer techniques for looking at cognition. So those are just two studies going on in my lab. There will be studies going on throughout Canada in other centers looking at aspects of cognition, undoubtedly.
Thank you for that. So if people are interested, would they just email you? Is that the best route to take?
Yeah, or they could, phone me at my
through the MS?
At my clinic, and the number, 416-480-4216. But they could email me, and I would certainly connect them with one of my research assistants, and we can go from there.
Okay, perfect. So 416-480-4216?
Yes.
Okay, I'm just going to put that in the chat pod right now so people can see that. Just bear with me here. Okay, so people can have a look at that there too. Okay, so I am cautious of time here. We've had a couple of different questions with respect to specific medications, and they tend to be specific to the individuals themselves, so I don't want to go right into those individual questions. But what I will do is generalize them and say that there has been some questions with respect to being, for some individuals who are on Effexor, and they found that at times, it doesn't seem to be doing the job even with an increased dose. There's others that have inquired about the difference between taking modafinil and forgive me, I'm going to mispronounce this, the vortioxetine, VORTIOXETINE. So maybe, in the limited time that we have, just speak sort of maybe high level on some of the differences between those three medications.
All right. So Effexor is an antidepressant drug. Vortioxetine is an antidepressant drug. Vortioxetine is a newer drug than Effexor. It has a different side effect profile. Vortioxetine doesn't cause sexual dysfunction, and it's not linked to weight gain. Effects or might be associated with both those side effects. Modafinil is not an antidepressant. Modafinil is a treatment for fatigue. It's also known by the name of Allertec, and you give it to someone who is struggling with their energy. Now, individuals might take vortioxetine plus modafinil or Effexor plus modafinil. That certainly is not contraindicated. It all depends on what the clinical problem is. But you must distinguish between depression on the one hand and fatigue on the other, because the treatments are different.
Thank you for that. There's also, and I do want to point out that my colleague here from the MS Society of Canada, that there's a lot of information on their website, mssociety.ca, and I'm just going to copy that as well. That includes information with respect to cognitive challenges in MS and some of the different, support mechanisms that are there as well for you to inquire about if you're so interested. So please, I invite you to, if you haven't already, to go and check them out and that website, because there's a wealth of information there as well that they do such a great job in providing to patients and people that have been diagnosed. So it's 7:31 Eastern, where I am in Ontario. So that means it's time to call it a close. And I just want to say thank you to everyone for their participation this evening. It always makes for a wonderful event when there's lots of inquiry and discussion and questions. Dr. Feinstein, we certainly put you through your paces today with respect to our presentation and then handling all of the questions that were thrown at you today. So thank you so very much for your time today and the time that goes into preparing for an event like we had this evening. So thank you for that.
My pleasure. Thank you.
I do want to provide just 3 reminders to everyone before we head out this evening. Just number 1, that a recording of this webinar will be available on the MS Society of Canada's website within a week. I have posted in the chat pod, but I will repost again where you can find that. And then today's events are the 5th of an 8-part learning series, so you can I invite you to stay posted with respect to future events. And again, you can go to the MS Society of Canada website to check those out. And then finally, you'll all receive an email very shortly just requesting your participation in a survey from MS Canada. So please keep an eye on your inboxes for that. It doesn't take very long to fill out, but it does help us and the Society moving forward. We do have Laurie Murphy on the phone from the MS Society of Canada. Laurie, I welcome you to say some final words, and just as a reminder, it's *7 to unmute your line.
Thank you, Jillian. I, too, want to thank Dr. Feinstein for that informative presentation. And I would also like to thank everybody who was on the line today as a participant. If you do want more information, again, yes, there is our website, or you could contact the MS Society and speak to an MS navigator. That number toll-free, and I'll share it with Jillian here in a minute, is 1-844-859-6789. And there's also an email option that would link you to an MS navigator, and you can get some of those additional questions answered possibly. But thank you, everyone, for participating.
Wonderful. Thank you for that. And I just posted that on the website, too. So thank you so much. I'll post one more time just the resources or that link on how to access both past events and also to get information about our future events that we have coming up. We still have a few more before we call the end of or the beginning of the summer, so that would be great. And again, if you're interested in looking into more research, then there's that phone number, that 416 number that Dr. Feinstein provided over the phone. So, so if you are having, someone has mentioned that they had problems accessing the slides. If you are having problems, here, I'll just put in the direct link to Brain Exchange, and you will find it listed under the event that for tonight, so you can find it there too. So it should, there we go. Okay, everyone, so thank you very, very much for your time this evening, and we'll call it a night. Thanks again, and I look forward to hopefully seeing you next month for another event. Have a good night, everyone. Take care. Bye-bye.